So welcome everyone. My name is Kevin. I'm from the United States. I work at the University of Philadelphia. I'm a medical physicist there. And I have with us Whitney Benson. Whitney, I apologize if I'm not going to do you full justice, but from what I've seen of your posters and other talks, your dedication to global education is fantastic. And I am very much looking forward today to your talk on IGRT with CBCT.
Thank you. I'm really excited to be here. Thank you, everybody, for joining, and Kevin for being here and being the moderator.
Right. Well, I'm going to stop sharing that side. So it is all yours, Whitney.
Okay. All right, let me just see how I share my screen. Oh. Okay. Does that look right to everybody?
Yes.
Yeah, okay. Looks great.
Okay. Sorry. Get back to this first page. Okay, so today we're going to be doing image matching workshop in regards to CBCTs. I'm Whitney Benson. I'm a radiation therapist at Stanford. I've been a therapist for about 9 years and at Stanford for about 7. Thank you all for being here. I hope this is helpful. Please ask any questions if you have any questions at all. We're going to have a lot of videos to go over a lot of things. Okay, so we're going to get started here. So to start, we're just going to talk about when and why we do CBCTs as opposed to just taking a regular set of images. And then we're going to go over matching, how to match different anatomy and tips that we have for each particular anatomy. I don't know how to... Okay, so we do cone beam CTs to check a 3D position. We also are able to monitor respiratory motion. So instead of just getting one image at a brief moment in time, you're taking a scan throughout the whole breath hold or the breathing pattern. We also are able to check soft tissue such as your bladder, your rectum. It's very helpful for pelvis cases where those village can make a big difference in where we're going to be treating. Also, soft tissue as lungs and sarcomas. It helps us determine if the patient has gained weight or lost weight, and if we need to rescan them, tumor response, and then any unforeseen anatomical changes, such as like a collapsed lung or a pleural effusion that might move the tumor in a direction that we don't want it to. And then it also helps us check bolus placement. So the cone beam is a great tool. I really like it. So when do we do a CBCT? The CBCT should be prescribed by the doctor. The doctor should determine if they want it on the first day, if they want it weekly, if they want it daily. And then I think the therapist's job is to, if you ever feel like maybe we should be cone beaming this, to mention it to the doctor. So if they just ask for a cone beam on the first day and you notice a significant shift, then it would be your job to say, maybe we should cone beam this more often because the bony anatomy doesn't actually line up to where we're treating or where we want to be treating. And then also on the Elekta, it's my understanding that KV and MB images can be difficult to do, so they prefer just to do cone beam every day. However, we do want to consider the ALARA aspect. We don't want to be overdosing our patients. So in the event that you are cone beaming daily and the patient is not setting up correctly, so you have to take more than one cone beam, we want to prevent that as much as possible. So like remarking ISO or remembering like, oh, this patient always needs to arch their back. Also, just taking some KVs in advance before you do the cone beam to get the patient close to on before you do it, especially if you have a refilm policy. Like we have a refilm policy. It's like 1 cm shift greater than we need to re-image the patient. And so when that's taken into consideration, you should probably start with a KV pair if this patient had to do a second cone beam one day. So this is a nice image. So it shows you the first treatment of the sarcoma, and the tumor was pretty large. And then right here on the final treatment, it's much smaller. So this is a good outcome, but you can see now that the PTV is kind of in air. So cone beaming this like at least once a week just to confirm that we're still treating where we want to be treating, and the patient doesn't need a follow-up CT to recalculate the plan, or maybe even the doctor could just adjust the contours if they want. So cone beaming really helps in these situations. Here's some other images. We have an abdomen here, and you could see these fiducials are pretty on, except for right here, they're a little bit off, but the therapist has stuck to the tumor volume. And so that's helpful for abdomens. And then right here, you can see that the bladder was not quite as full. And so this probably helps us see this. This one, we're right next to the kidney. So it's always a good idea if you're near a critical structure to do a cone beam to make sure you're not treating the kidney more or whatever critical structure it is. And then on this film, this is really nice because you could see the tumor response. It's purple is the original CT scan. So you can see a lot of purple right there. And then green would be S. So because you don't see any green, you just see purple, we can tell that the area in the nasal cavity has basically disintegrated. So the radiation therapist did a good job treating that. It's being very effective. This is just showing what it looks like with the purple and green colors before we align. You could see this massive amount of purple right here. And then also like the bony anatomy doesn't align. So this is all pretty off. And then when they shift it on, everything looks more flush. It's like a grayish color now. The Elekta uses a lot of the purple and gray color for alignment. And then I wanted to show this. This particular patient, they added a bolus after we did the CT scan. And so it was really helpful to have this bolus contour and do the cone beam so that we can see that it's still flush and in the proper position. So I'm just going to play it. So the PTV is the red. This blue is where the dosimetrists have determined the bolus needs to be. And you can see as we scroll through it, there starts to be this gap down here. So in this case, I wouldn't re-cone beam the patient, but I would go in the room and just bring the bolus a little bit tighter, tape it down a little bit more. So the cone beams are really helpful with bolus placement. And then we could also tell like, oh, this needed to be adjusted a little left, right, or sup inf. We just used a big piece of bolus because of the 3D plan for this case. And then here is on the Elekta, once again, the green and purple colors. And you could see right here that the bladder is not as full as it was on CT day. And so, but it looks like we're just treating this prostate area, and there's no valve in the treatment area. So depending on your physician, they might say like, this is okay to treat and just coach the patient to have a more full bladder. If we were treating nodes or the valve was actually falling into the area, then we wouldn't treat. So all of these are ways that we use cone beams to monitor like soft tissue for this instance. Here's another example that I wanted to show you of a dramatic anatomical change when doing the cone beam. This particular case, we're treating a rib. And so because this happened, we were still able to treat because it was a rib and not inside the lungs. But this patient has a pleural effusion. So you can see this is today's scan. And then when we scroll back and forth, you can see how much fluid has come up. So the lung has changed pretty dramatically. If we were treating, over here, the tumor would probably shift quite a bit, and we would probably need a replan, or the doctor would have to make the call if you just want to shift the tumor. So fortunately for this case, we're treating here, but cone beams are really helpful in these situations because if you were just to go to bony anatomy, you wouldn't even know that the patient had a pleural effusion and that the tumor did shift. If you guys have any questions, just let me know. I know I kind of talk fast. So yeah.
Please. And if not, I'll ask you a couple of questions that come up. So I had a question. So you made a good point with the CBCT and showing the pleural effusion. So would you say this is probably very good for using when you expect there might be large anatomical changes, I guess head and neck, lung, or these sarcomas that you had mentioned?
Yeah, that's an excellent question. I would say anytime you feel like something dramatic has changed, it would be a good idea to take a cone beam. So if it's not prescribed every day, you can ask the doctor, like, are you okay if we do a cone beam today? Sometimes, especially lungs, we get a lot of changes throughout the treatment. Or say a patient said like, oh, I just got my lung drained. That's probably a good indicator that you should do a cone beam. So yeah, or if you noticed a dramatic change, like you thought the tumor actually was getting larger or smaller, you might be like, can we do a cone beam? Or sometimes even breast tissue, you'll notice that the light field has a lot more flash, and you want to make sure it's actually a tissue change and not like a roll.
That was a great example. I hadn't thought about them. Breast. Thank you for going over those.
Thank you. So the downfall of cone beams is that there is a clearance problem, and we want to make sure that we don't hit the patient or the couch. And so every day when you do a cone beam, you want to go in and make sure that it clears. So if on the first day, they're centered and it clears, then you probably don't have to check every day. But if the clearance is tight on the first day, then every time you do a cone beam, you should go in and make sure that it's going to clear. We like to do a lot of partial scans, which kind of helps because you don't have to go a complete 360. You can just go 200 degrees for that. But also there's the option to center the couch. When you center the couch, you want to always make sure that you know where you originally started. So if you were like -7 over to the left and then you zeroed your couch, after you cone beam, you want to take into account what your shift was. So if it's like a half cm, then it should be 7.5 or 6.5. And then when you restore your couch, you want to note and look at your lateral or whatever you shifted from, and make sure that that matches your original number and not what you shifted to center the couch. So always making note of what your shift was is really a good habit, because sometimes, machines don't, they freeze or something, you have to restart, and you want to make sure that you're restored to the original position. If you're ever unsure, you can always just take a quick KV image just to verify that you're on. You could even just go in the room and look and make sure that the lasers is where your ISO is, if you do make ISO marks. So all of these should be taken into account when you center the couch. So this is just a video showing you on a Varian machine them acquiring a cone beam CT. So this is obviously the ideal world. The patient is very centered, so you're not worried about clearance. And then this is a full 360-degree rotation. All right, so what do you see in a CBCT? We get 3 different planes of view. We get the sagittal, which is splitting the patient from left to right. So it's kind of like your right lateral image. And you can scroll through to see different sections of this. This is probably my favorite starting section plane. I like to start on the sagittal, get our sup inf on, our ant post, and then fine tune with the others. So the coronal you can also use to get your sup inf on your left to right. So it divides the body from anterior to posterior, and it's also called a frontal plane. And then we have the transverse or axial plane, and I like this one mostly for fine tuning. And yeah, we use this. I feel like when I scroll through a CBCT, I look through this the most. The other 2, I just try to get on in and out and in the ballpark. And so now we're going to do an overview of software and tools, and then go over demonstrations for a specific anatomy. So for Elekta, I don't work on Elekta, I work on a TrueBeam. So I've done quite a bit of research and reached out to as many therapists as I could to get all the information as far as cone beam matching. And you just want to remember that the approach is the same, even though the software is a little bit different. How we line up a cone beam is the same. So we'll show you videos from both Elekta and Varian. But this was a really good YouTube video, so I'm going to play this for you. I didn't make this. These girls made it, and they did a really good job. So I'm going to play this just to start.
I was going to say, so I've actually worked a little bit now on Elekta, on CBCTs, and you're right. The approach is the same concept as doing it on a TrueBeam. The steps are a little different on an Elekta, but it's usually the same tools where you have the ability to see the split of the CBCT and the CT scan, the image difference color, like you mentioned, the green and purple. But usually I would approach it the same way, scroll through and just line up as best as possible.
Yeah. Okay, well, maybe if you guys have a chance and you want to look at this link later on, I thought it was really helpful. And then I'll also go over the different tools too. So let me just make this smaller. So for the Varian, I wonder if I can. This is the Varian screen and offline review, and it's very similar to what they use on the console. So this is the save button. This is if you want to adjust the window leveling, and then there's an auto match window leveling here. You could zoom in and zoom out. If you want to grab the image and move it, you can use that tool. Just undo your shifts here. This one, you could switch from which planes of view you're going to see. This is where we select our structures. We have, if you want to create shifts, you could just click this and it opens up to make your shifts. And then there's the auto match feature. And then over here is the color feature. For Varian, it's orange and blue, but for Elekta, it's purple and green. I actually like the purple and green a lot better. It's easier for me to see. So Joshua is gonna do a video using these tools, and then we'll move on.
Okay, so we are going to be looking at an image here of a patient who's getting treated for a tumor on the gums here on his lower gingiva, lower right gingiva. And this image has already been approved. So we're just going to be looking at some of the tools as well as taking a look at the registration that can be accomplished on a regular couch without 6 degrees of rotation, roll, pitch corrections. This is just on a trilogy with a regular couch. But let's look and see what this looks like. So we're going to go basically over a lot of these tools up in here. So let's start out with something we should all try to keep in mind is keep our eyes young and healthy as possible. We're going to magnify it up a little bit. And then let's get oriented over here so we don't have a whole lot of mess of colors going on. So what might we want to look at? Let's drop this down. Oh my gosh, there's 1,000 things contoured here. So clicking up here, turn it all off. And let's just quick scroll through here and see what we as the radiation therapist might be interested. I'm looking for spinal cord. I'm looking for the PTV, and let's turn on both PTVs. PTV 45 will be probably the lymph nodes in the area. PTV 55 will be looks like the target for this person. And looking through here, maybe mandible, since it's gingiva that we're treating. Let's leave those on, just so it doesn't get too busy there when we're scrolling through. So we can click out here and then go back to our image. So down here, we're gonna have our blend bar. And I don't,
Shoot. I'm sorry.
right, the lymph nodes. So down here, we're gonna have our blend bar. And I don't really like that windowing there. So let's see what the auto window here does for us. We like it. I like that better. So right now we're looking at our planning CT, and here's our cone beam. Planning CT and cone beam. And if you're on one side or the other, pressing Control A, of course, will allow us to flip between the two. Other buttons that might be interested, maybe you zoomed in too much, so you can zoom out a little bit. Now this is pretty well centered here, but let's say if you wanted to change where it is in the window here, you can move these around here and there. That's not doing anything but panning where the image is in this field that we're working with. But every time you turn something on in here in Varian, you got to turn it off. Now this layout here, I don't find very many other useful views for cone beam, but I guess if you wanted to look at 4 views, so you just wanted to look at what the plan is up in this window, you can do that. But in 6 views, you can see for yourself. I don't think it's very useful. This button's gonna move your dashboard up and down, gives you a little more room to work with. So sometimes that's helpful. I like that. This target button, you can turn that on and off. Then if you get away from ISO center for where your images are, you can always right click over here and move viewing planes to ISO center. So you can see actually that the main PTV is actually two spots here. For these red circles are showing the PTV. And if you forget what the circles are, you can just click them on and off. Okay, that's the PTV. That's where the doctor wants the main radiation to go. So looking up here, you can also see this, you can measure distance. As a therapist, you don't really need it too much, but sometimes the oncologist might want to know, say, how far is the PTV to the cord? So you click on the ruler, you click here once, and then click here again, and then it says, oh, it's about 5 centimeter, doctor. So that might come in handy. You can click it off when you're done with it. Here, you're measuring angle. I've never found a use for that. I don't use these buttons either, but you can play around with them. They're not going to cause you any harm. These buttons are what you're going to use for the matching. This image has already been approved, so we're not matching anything. But we can still look at it using the split window tool is another way. Instead, if you don't feel like pressing Control A and scrolling through, you can use this. This is my favorite tool, but I find more people like this one. For some people, it's easier to see this. So inside the rectangle, you're seeing the cone beam. Outside the rectangle, you're seeing the planning CT. So we can see here that the patient's neck is perfectly, and I'm going to scroll through using the thumb roller on the mouse. So you can see the spinal column isn't perfectly matched, but the doctor has prioritized matching here in the target. The mandibles on perfectly, and you can see down here that spinal cord's far enough away from the treatment area that it's acceptable. We don't have the 6-degree couch. I'm gonna just roll through here. I like to think of this as like the little piggy tail to move the different views. So we look on sagittal, you can see this patient is quite kyphotic, so it's always a challenge to set up kyphotic patients. So here in the C-spine, here it doesn't look perfect, but again, the doctor's prioritizing hitting the target in the buccal mucosa. Other tools, so I'm going to turn this back off so we can go back to this, and we're on our blend now. So I'm going to blend to 50-50 here. So some people, their brain works better when they turn the colors on. So when you have this color blend on, you can kind of, it's never been one for me, but I know a lot of people like it. And so what's going on here is you have the CT scan has a blue tint and the cone beam has an orange tint. And then when you go to 50%, you can kind of see where they don't match up. If the colors aren't, you know, if you see like a pure orange here, or like a pure blue here, you can kind of see where they don't match up too well. Again, my brain has never really found a lot of use for this, but not everybody's brain and their eyes don't work the same. So some people love this, and that may be you. But there's another one here. I'm really not, to be honest, I'm not sure what this is for. I guess if you're like the Predator from the movies and you see everything in infrared, then this one might be interesting for you, but I don't see much use for this. So this is about all the tools that I would use when registering images. Oh yeah, and these scroll bars are gonna allow you to, instead if you don't wanna press page up, page down, or use the mouse scroll button, or maybe you don't have a mouse that has a scroll button, you can page through using this bar over here on the sagittal, and you're paging through your transverse slices, and you press Control A as you go along, and then you see where they match up and where they don't match up. Now, finally, don't underestimate the importance of just looking at the cone beam, which we got here. You can see that this is over there at 100%, and you can see the contour of the mandible, for instance. The contour of the mandible is on perfectly here, okay? Now, we can see it down here that the spinal cord, here, let me get these bars out of the way, because that's not helping see. But you can see that this green line, which is the spinal cord, should be a little more in here in the center of the lumen of the spinal vertebra. And it's actually not. So what this means, so we know that the spinal cord is actually more like in the center here. So the spinal cord is a little closer to the treated area, but being that it's not within millimeters, the doctor has approved this film. It's okay, but sometimes it's good just to look at the cone beam with the selected anatomical contours from dosimetry. So, and it depends on a case-by-case basis, but I find it to be very helpful to look at that. So I'm going to look for a patient who hasn't been approved yet, and then we can hopefully go over how to match.
Okay, so this is the Elekta software, and I just wanted to show you what's similar here. So this red circle is circling this box, and that shows you the purple and green colors. And they look gray when they're perfectly aligned, and kind of white on the bony anatomy. And then you could also get that checkerboard, that split screen that Joshua said is his favorite. So that's also something you could use on Elekta that Varian has. And then this screen, this particular button switches back and forth from the CT to today's image. And then these can help you zoom in and zoom out. This button helps you select your contrast, or your window leveling. So if you wanted to adjust it, you can click this, and it has different options. And this button, it helps you could like realign back to ISO. So say you've scrolled too far, you could bring yourself back to ISO. This box right here is our registration box. So you want to put that around the area of interest, as well as anything you want the computer to take into account. So when you do your automatic registration, it looks at that and will help you provide you shifts. And then this is where you select your structures. So you can find out where your PTV is and put on any organs at risk. And then down here is where you will do your shift. So if you want to shift left and right, if you want to shift sup and inf, ant post, and then this is if you have a 6-degree couch, you could do the roll, pitch, and yaw. So on the Varian, you could use your keypad, but I believe for Elekta, you actually got to click these buttons. So that's a basic overview of the Elekta console. And you could see many of the functions are the same on Varian. All right, so we have our first Zoom poll question. So
I'll get that set up for you. All right, everyone, you'll have a poll on your screen. I'll give us a few seconds to answer. And Whitney, while we're waiting, we had a question in the chat from Krishna. She was asking, how many CBCTs is your staff allowed to take before you would, perhaps get the patient off the table? I had mentioned that Penn, we allow 2 CBCTs before the physician or physics is called over to approve a third. And after 3, we would not treat the patient that day.
yeah, I would say 3. Once, just same thing around. If we have 2, then we'll probably start alerting the physician. And then if 3 is not working, then we'll probably send the patient home for the day.
Okay, great, thank you. Yeah. Yeah, good. Yeah, they had mentioned like about patient dose, and I figured that would be similar. So thank you. That's good insight. All right, looks like we have quite a bit of responses. I'm going to give us we're at about a minute, about 5 seconds. So I'm going to hit stop, and we'll see where we're at. All right, thank you, everyone. So it looks like we kind of had it between A and B.
Yeah. So this looks good. So we strongly recommend actually selecting your contours first. So we want to see where we're treating. I would say if you were to center on ISO or align your bony anatomy and then select your contours, that wouldn't be wrong. It's just we always want to make sure we know what we're treating. And sometimes when you have multiple sites, it's a good idea to make sure that you have the selected contours first.
To that point, Penn, we have like a treatment instruction sheet that will mention the CBC, the PTV or CTV to use for alignment. Does Stanford have something similar?
Typically on the first day, we'll just discuss with the doctor, like which PTVs are we using. So it's not always the same it's kind of a case by case for us at Stanford.
Yeah, but great. But that's a great, so it's clarified up front, what to use.
Yes, yeah. Sometimes there's so many PTVs, so you're like, which one are we using?
Yeah, that's a very good point. Yeah, with SIB or cone downs. Yeah. Thank you.
Thank you. Okay, so just going to make this box smaller because I can't see. Okay, so how to image match on a CBCT. We select all the contours that we needed. So your PTVs, any critical structures that are nearby, anything that you want to use for alignments. And sometimes like bones are really helpful. Then you're going to align to bony anatomy. Start with determining your sup and inf using a sagittal or frontal place, and then fine tune on the axial. And then you'll check your PTV and make sure that the area of interest is on. Sorry, my cat is here. We have, sometimes you might need to reposition the patient. So you don't want to just treat just because you did a cone beam like we said. You want to take into consideration what you're actually going to be treating. And then you want to scroll through and check all planes, make sure everything looks good before you apply your shifts and treat. Okay, so this is the demonstration of an Elekta. This particular patient has a really large thyroid tumor. I'm just going to explain what she's doing while she's going through here. So to start, we have this clip box, which helps with the automatic registration. So she's going to make sure that this is around the area of interest, as well as, you know, the spine. So we can make sure the spine is rotated, the airways in there. And so to determine if this is in the correct spot, she first is going to select her structures. And so she's going to bring those up now. The first one is just the tumor volume. And then she's going to get the clinical tumor volume. These are the nodes that are nearby that we want to treat as well. And then here's the clinical treatment volume. PTVs right here. So this PTV is going to 4,600. And then there's going to be this orange PTV that's going to go to 5,250. So once she has all of her selected contours on, so she knows where she's going to treat, she makes sure that this box is encompassing everything that she wants it to. Then we're going to look at also the bolus. So they don't currently have the bolus on. I actually think it would probably be helpful to start with the bolus on. That way you know that you have it on. But she can now see where the bolus is supposed to be. In this particular case, I think they're going to put it on top of the mask. So after the first day, if you confirmed with your cone beam that it looks good, then you know that, you know, it's sealed to the mask. And as long as the patient didn't lose a lot of weight or the mask didn't shrink too much, you don't really have any air gaps. So now we're going to do that purple and green colors. You can see, so the green is today's image and the purple is the original CT. So right now you can tell it's extremely off. So she's just trying to show what it looks like. And then you can see that she can drag her image as well. So you can use these buttons to move the patient, or you could just click and drag to get the patient aligned. So she's going to get it into position where she thinks it is. And then she's going to, one more time, show the automatic registration here. So you'll see the computer compensate and determine what it thinks is correct. And now she's just going to scroll through, take a look, make sure everything looks good. So you can see it's nice solid gray where we're treating. So that's a good indicator that we're on. Also, the bony anatomy looks fairly well aligned. There's a little bit of green, but overall looks pretty good. She's adjusting ant post and sup and inf to get a little bit more fine tuning on to get all that green out of there. And then this is that split screen window. So if you prefer this over the colors, or you could do both if you like, you have the DRR and then today's image that you can compare to. So this is the same tool that Joshua was using for the Varian. Yeah, that's
Sorry,
she likes
my meeting.
and they will apply it. So now that she's checked on all planes, her position, she's going to apply her shifts. And then now Joshua was going to do a demonstration on matching on the true beam with a 60 couch.
So we found a patient where the doctor didn't approve the image yet. So this is actually in an offline review. This is not at the treatment console. So it's going to look slightly different when you're doing it live at the treatment console. But the tools are basically the same. And referring to the last slide we looked at, where we're just scrolling through and looking at a successful match, you're going to start with some of the same principles. So I would always suggest you go here, turn everything off, look for your PTVs. Now we have a ton of PTVs, but we're just going to go with the main ones here, the ones that don't have a whole lot of other descriptions on there. We'll talk about what those are. And let's turn on spinal cord. And then a lot of times the doctor's gonna talk to you about other things that you're gonna need to look at. I know that brainstem is really important too, so we'll look at that. So we'll click this off. Okay, now wait, click it back on. Now that brings up a point. Just clicking this will turn this geometry off or on. So if you click the drop-down menu, then you choose what you're looking at. That's an important thing to know. Okay, so I'm going to use my magnifying glass and I'm going to zoom to about like that so that my eyes are happy with me. And now turn your magnifying glass off. And now you're going to click here on the target thing, move viewing planes to isocenter, because you want to look kind of at the center of things to start out. This is a blend. You can turn it to one side, you can pull the blend one to the other. Wow, can you see how far that bony anatomy is off? Now, for me, I prefer to use this split window, but you don't have to, and it's hard to actually watch somebody else do that. It's kind of hard to watch somebody else because the way our mind's eyes work is we know where we're looking and that's when we're using this window. But for a regular match, I'll use this one. A lot of people will use the rectangle or called the spyglass, but we're going to turn those off. And just for illustrative purposes, I'm going to use the Control A and move through this, okay? So you can see here, this is treatment planning scan. I'm sorry, this is treatment planning scan. This is cone beam. You can see how far off it is. Now using our arrows, you can't see me doing that, but I'm using the arrows on the keyboard. I'm gonna look here and I'm gonna look at that cord and I'm gonna put that cord right in the middle of the bony anatomy. And now I'll press Control A and you can see that's starting to look like it's more on. And you can see here the larynx starting to look more on. But that's just one slice. So let's scroll up using the scroll button on the mouse. Okay, this is starting to look okay. You can see here, this is the main target at the base of tongue. Let's look at another plane. Let's look at the sagittal plane, which is, to be honest, I feel like it's more helpful. Okay, actually, superior inferior doesn't look too bad either at the anatomy. I'm pressing Control A. And I'm gonna look here at the basis, I'm sorry, at the, is that the vomer or the, yeah, I think that's the vomer. Maybe it is the base of skull. Well, anyway, this bony anatomy here, let's see how that looks. It looks like a little off in and out, but it may just be a little rotation because I know that this image was taken on a 6 degree of freedom couch. So I can actually say that actually that rotation looks like, can we maybe rotate it a little one way or the other, make it a little better? You see where my mouse is in the upper right-hand corner over here? I'm outside of this little red dotted line. That means I can manually adjust the rotation. Well, let's look at the frontal plane. And I'm gonna drag it a little more central. I'm panning, see here? Okay. And so something still looks a little off up here, in and out. You can see here, see how it's a little lower here on the treatment planning scan. The bony anatomy is a little higher up here. So that's off just a little bit. So it needs to come out like that. Is anybody else buying that with me? So you can really fine tune things a lot here with the 6 degree of freedom couch. And you see a little, this is pretty good, but there is probably just a slight amount of rotation too. If you look at the transverse again. So I'm up near the top of the field here. I think it's off a click or two, left to right. I like that rotation, but let's scroll down here. So we're still treating some lymph nodes down here near the shoulders on this patient, as is outlined here in yellow. So how far is that off right here? You can use your split window. You can see the bones off a little bit here. I'll get this out of the way, this scroll bar out of the way. So you can actually measure how much off it is. So I'm gonna click the distance. I'm gonna go to the edge of this bone here, click once there and click once there. 0.2 cm. This is a great match. I'm not gonna fine tune this anymore. The back of the vertebra in the lower part of the field is off by 2 millimeters. I'm right on up in the upper part of the field. This doesn't apply anymore because it was on that other slice. That looks perfect. Soft tissue looks perfect. Mandible looks great. I'm gonna call it a day and we're gonna submit this. We're gonna treat the patient and submit it for the doctor's review.
Okay, and then here's another example on the Elekta. You could see the diaphragm is slightly off here, but the tumor right here is on. It's nice and gray there. And then this head and neck, you can see all the vertebral bodies look, you know, well aligned, so you can differentiate between them. And so this is just what an ideal matching looks like on the Elekta. So this is a really exciting feature that I learned about on the Elekta. It's a 4D acquired CBCT. So I'm just gonna go through it with you. So to start, she's just gonna go and she's going to, right now she's just on her original CT scan and she's selecting her PTV. So she wants to know, where are we treating? And now that she can see it, you can see they have a good margin around the tumor, but it's hard to tell right now if it will include the motion of breathing. So those are just the different window leveling you can choose. And so and then she's just making sure her clip box is wrapped around the tumor where we want it to be. The PTV is in there. She's shifting back to ISO, which is always helpful to go back to ISO. And then you can see the green and purple, and you can actually see the motion. So it's pretty neat. The purple you see is not moving because that's just an image at one point in time, but the green is moving. So that's the acquired 4D CBCT for today. And you could see it's just turning a little bit green at the top there. So it looks pretty good. Even with all the motion, it's still within the PTV. And then she's just switching to today's scan. So this is just today's scan. And again, you can see the motion. It gets close on the bottom, but overall it looks really good. This is not a feature that the TrueBeam has, but I think this is a really nice feature, especially if the patient is not able to hold their breath.
I think you hit it. Yeah, it's one of the most interesting features to me of the Elekta machine. It comes default, like with it's I can't remember the protocol name. It's a Capture 4D. But yeah, you can assign it to that patient and then take it. And I think you're right. It's like the best use of this would be any patients where you would expect large motion, ones that don't have DIBH or a compression belt or other things that might limit the tumor motion.
Yeah, I was pretty impressed when I saw this. I was like, this is very cool. So yeah, she's just going back to the purple and green once again, thoroughly checking on all planes that this is included. Shifting back to the ISO center. Now she's just doing that split screen that Josh was using. So this is all preference. Like if you like the colors, you can use the colors. If you like the split screen, you can use the split screen. And that's the original reference image. So yeah, very cool feature. So I just wanted to show you guys an example of a patient who doesn't have a 4D scan. So, and also this particular patient, when we started them, their internal anatomy didn't align up with the bone. So the doctor originally ordered a cone beam CT once a week and KV daily, but you can see when the bony anatomy is significantly off. So I'll show you one more time when you slide back and forth, you can see that the bony anatomy didn't quite align. And then also this is a good time to adjust the window leveling because it's really hard to see. So I'm just gonna switch the window leveling to a lung. That's an option that's on the Varian. For Elekta, they just have like soft, medium, hard. And so for this case, the doctor asked us just to stick to the airway and then make sure that the tumor is included. So you could see how we don't really see the breathing pattern, and it's definitely much more difficult to align. And this is a point when a therapist would want to ask the doctor, like, maybe we should cone beam this every day because it didn't match the KVs at all. I think the shift was like a CM between the bony anatomy and the cone beams. So I just want to give you an example of when things aren't perfect, because as we know in radiation therapy, it's not always perfect. We're treating human beings and things happen and change. So, and we need to be able to decide if this is something we can treat and treat it to the best of our abilities. So, let's see.
So we're looking
So Josh, I was just going to show aligning a prostate with
here at a patient with an intact prostate. This is the treatment planning CT. There's fiducials, rectum's empty, bladder's full. I'm going to put on our preferred chessboard for matching. So typically you can just start with the bony anatomy using the arrows on the keyboard to match up the pubic symphysis. That's a good starting point. Now, a lot of times, including in our center, you're not going to necessarily use the bony anatomy as the end result for matching, but it's typically a good starting point. So we're going to look in all three planes, make sure everything's on in all three planes. So I'm using the arrows on the keyboard to match up all the bony anatomy. Starting to look pretty good. You can see the rectum matches up the bladder, the pubic symphysis. And I'm gonna scroll through the axial plane now, look at everything. And you can see, oh, now how come my seeds aren't on yet? So I know this seed should be on perfectly. So I'm off a little bit here. If you look there on the CT, seeds are off. So I'm gonna bring up my frontal plane and I'm gonna finish by matching those seeds. So I'll use this to cursor through to get to that plane. And then I'm gonna see why are those seeds off a little bit? We want those on perfectly, just like that. Now I'm gonna scroll through, check those seeds in this plane, those fiducial markers. I'm gonna scroll through to sagittal, look at that, maybe tweak it a tiny little bit there. Tiny little bit there. And finish up with the transverse or axial plane. Just scroll through, seeds are on, bony anatomy is reasonably on, and everything's looking really good here. And I think we can apply these shifts and treat the patient.
Okay, and then this is an Elekta where they lined up to the clips that they have here. You could see that they've kind of split to the best of their ability. The patient's bladder is pretty full. There's no critical structures in the field, so the rectum is nice and empty. So this would be also a good example of treating using fiducials. And then this video is just going to show you when the patient has node involvement. So it's really important to select all your PTVs, because if you didn't have this PTV selected, you wouldn't know that you also need to focus up here. So the patient has clips and the therapist aligned up, to the best of their ability to the prostate. Let me just show you the rectum is actually more empty than it was in CT, and the bladder is almost perfect. So then they would need to determine if the nodes are still within the treatment volume. So the margin is a little bit larger. You could see it's on the nodes typically, but you can see they're right borderline. So in this case, I would probably ask the doctor, like, are you comfortable treating this? There's not a whole lot you can do because the patient's rectum is empty and the bladder is full. So I think in this particular case, the doctor said we can treat, but we always want to take the nodes into consideration too when treating a pelvis. Okay, we have our next Zoom question.
All right, I'll have that up in one moment. There's a few questions in the chat that we could take a look at as well. Prostate, here we are. Launch. All right, you should all have quiz question. We'll wait about a minute or so for some answers. While we do that, let's take a look at the chat. Let me see here. A good question was, it was a question about phase and amplitude gating. Do you at Stanford do any gating like that at treatment?
Yeah, Stanford is very avid on their gating. We do phase gating, we do gating on expiration, we do breath hold gating, we do gating just to avoid extremes. So like we'll just put the box on the patient, and in the event that they cough or something, we'll turn it off. The beam will shut off. So I didn't cover gating scans in this presentation, but we do it there.
Oh, no, thank you. Yeah, because I think that was their curiosity, was like the difference, and that makes sense. So you would use it at times where you don't want extremes, like a patient maybe, depending on their, if their lung, I guess if they're taking very big inhales or deep exhales, and you only want like the central motion,
yeah,
between phases.
It's very rare that we would treat any kind of abdomen or thorax without some sort of gating.
Yeah. Here, and look at our poll. All right, I'm going to end here.
Okay, so yeah,
Looks like B is our number one.
Okay, that's perfect. So yeah, B is correct. So we always want to check the bladder filling and the rectum. Even if our fiducials are perfectly on, you still want to make sure that your intestines, the patient's intestines, are not in the field or close to the field, especially with prostates. They get a very high dose. Okay, Joshua was just gonna go over checking bladder.
So this is a patient who we're treating for prostate bed and nodes, and I've taken out some of the contours to just clarify what we're looking at here. We're looking at a case of bladder being emptier than a simulation. So here's our CT simulation images. You can see the bladder's this full. Today it's less full. See in here that the bladder's not as full as it was. Looking on the frontal plane, you can see it even more so. And on the sagittal, even more so. Up here, bladder's just this full. So again, we'll look at the images on here. Scrolling down, not as full. All the targeted anatomy is on. So we're going to look at another day when the bladder was closer to the sim, not quite as full as it was at sim. So this is about a week ago, the patient's bladder was more closely matched to simulation, still not quite as full as simulation. You can see there's kind of a sliver there at the base of the bladder. You can see it on here too. There's SIM. Not quite as full, but better than it was today.
So it's always good to know your doctors and how they plan. I have several different doctors that work, and some doctors account for the bladder to be less full. So they're like, oh, this could be 70% or 50%. Where other doctors they want it to be to the max. Like I have some doctors who are like, do not treat unless that bladder matches the contour, and that's built into how they design the plan. So I think it's always good to have a conversation with the doctors and know what their expectations are and how they're planning for these patients. This is just another example on the Elekta of them, checking the bladder, aligning the clips to their best ability. And then, so when you're aligning a prostate bed, you always want to align bony anatomy first, then shift to your soft tissue. So you want to align the bony anatomy just to make sure the patient isn't like rolled or pitched too much, because then the attenuation, the beam will be different and your match is not as good. So you always want to make sure that the patient is lined up well, and then shift to your soft tissue. Check your bladder filling in your rectum, verify there's no critical structures, and then scroll through all planes and treat. So we always want to be very thorough when looking at our cone beams. Don't just auto match and then treat. So this is a OBGYN case. So for our OBGYNs, we typically do a KV pair daily, and we check to see if their fiducials are aligned. So if they do have fiducials, it's really helpful. In the event that their fiducials don't match their bony anatomy, we would acquire a cone beam to check to make sure they're still within the PTV in a 3-dimensional view. And so now you're going to see usually GYN patients get a lower dose, not quite as high as prostate. So they're a little bit more forgiving, but since they have a lot of nodes involved, we want to stick to the bony anatomy. So you wouldn't shift to the seeds like you would a prostate. You would just confirm that the tumor and the seeds are still within the PTV. So you can see this patient's rectum is much more full today, and that's pushing her seeds forward and her tumor, but it's still within the PTV. And so for this, we would still treat this. And this is obviously still like a doctor preference. You want to check and see what your doctors say. But for our GYN doctors, this is how they like to treat their pelvises. And just rechecking the lining. So once again, bony anatomy is in a line. You want to check the surgical clips. If they're really off, then you're going to want a cone beam. We have a half cm roll. So if it's more than a half cm off, we would cone beam and just verify the tumors in the volume and the rectum and bladder are within. So for that case, I would probably ask the doctor if they're okay, because they had more rectum in the volume than was planned. Just to make sure the doctor is comfortable treating that. If you're ever unsure, always check. And then this is going to be an abdomen pancreas alignment from Joshua.
This patient has a abdominal tumor, a lymphoma of the pancreas. So this is the cone beam. We have a spotlight cone beam. See the small field of view. Let's go look at the planning scan.
No, wait, I did not
The
say
anatomy's off quite a bit. See the spine's off. And the pink area here is the kind of the target area. So I'm going to go to the ISO center. And I'm going to switch my views so I can make sure my spine is lined up in and out first. Using my preferred tool here, which is this checkerboard. I want to make sure you can see how far off we're on left to right. So we'll just start with the bony anatomy. This vertebral body is this one, I believe, but I'm gonna not assume that yet. I'm gonna look at another view. So bring it around to sagittal. Kind of use the different orientations of patient anatomy to verify that you're on the correct vertebral body. Your vertebral body is generally going to be your roadmap to getting the soft tissue on. You start out there to make sure you're at the right level. So you can see on this patient the curve of the spine. You want to look for anything that looks distinctive. So I'm going down the front of the spine here, and I'm making sure that the front of those vertebral bodies are correctly oriented. Let's go to the transverse view now. And using the arrow keys on the keyboard, we're matching. You can also look for little calcifications like in the aorta here. So basically just scrolling through, making sure that the anatomy's on. And you can use your anatomic knowledge. For instance, well, scrolling up, can we see a rib coming in? There's T12, right? So see that's the first vertebral body as we scroll through with the ribs. You know that's T12. So you know that you're on, but you know also each vertebral body will have a distinctive shape. So now that we know that we're at the right level, we can look at soft tissue. Cone beam's going to not have as good of soft tissue resolution. You can see a lot of artifact there from the air in the small bowel. But you have decent, so you can see part of is that the gallbladder or is it the liver? I think that's the gallbladder right here. But you know, we're just making sure it looks the same, same. It's not our job to be the radiologist. We just want to make sure that it's same, but so the target, it looks like there's lymph nodes in the periaortic lymph nodes, as well as the pancreas itself, which is sometimes hard to see. You can see it better here on the planning scan. Then you can actually see it on the cone beam. But long story short, you want to have your vertebral bodies on, and then look at what soft tissue anatomy you can look at. Okay, so the patient's anatomy will vary a little bit here. This is his kidneys. They look a little bit less robust than typical kidneys, but you can see on the frontal view over here, it's definitely his kidneys. So just basically go through, look at everything. Again, you don't have to know what every little thing is. You'll learn as you go along, but it's more making sure that the patient's distinctive anatomical geography is the same on your cone beam and on your planning scan. So scrolling through with the control A, you can also just come through here. You can see now that we're matching.
Okay, so again, it's the same steps when you align an abdomen. You want to start with the bone anatomy, make sure you're on that correct vertebral body. The patient is not positioned extremely crooked or anything, and then shift to your soft tissue, and then double check all your critical structures like kidneys, small bowel, spinal cord. And abdomens are really hard to see. So if you're ever unsure, I would always recommend to reach out to the physician prior to treating. Here's our Zoom question number 3.
Sorry, I realized I had the old poll up while I was doing all this. I apologize. There was a question in the chat about patient prep, like bladder and rectum prep. What have you found is usually the protocol that works best for, we could say like a GYN patient or a prostate patient for full bladder and empty rectum?
So, like, obviously it's a kind of a doctor preference thing. I kind of prefer like what is their norm, because if you give the patient an enema before their CT and you pump them full of water, the idea of recreating that every day is it's really challenging. So my preference for prep would be to just have the patient have a bowel movement 2 hours before their scan, and then drink about 20 to 32 ounces of water 1 hour before, be finished drinking 45 minutes before the scan. I like to kind of, that way all the PTVs are contoured and the critical structures are more taken into account. But I do have doctors that they want an enema, so we kind of got to, do whatever the doctor asks. So different, I have one doctor he just kind of wants their norm, and then other doctors who want enemas, and for them to have an extremely full bladder.
Great, thank you for that detailed answer. Yeah, because I know that could be a very tough one, as you mentioned, to try and get the consistency, but also not to have the, going too far to where it would be impossible to do.
Yeah, I do have one doctor who likes to do a full bladder and empty bladder scan, and then she creates like a adjusted PTV to compensate if their bladder is less full. I really like that idea. It's very helpful.
Oh, I like that. Oh, that's a great idea. Yeah, I've seen that for GYN patients, especially for, any vaginal cases or uterine cases. Yeah, but that makes sense to do it generally.
Yeah, yeah.
Idea.
For GYN, we do it for all the cases too. That's a good point. It's a little bit, it tends to be a little bit more forgiving in GYN because the dose isn't as high, but.
Makes sense. Great. Looks like we have a very overwhelming amount going for C.
And that is correct. So you always want to, when you do the auto match, you always want to not just auto match and treat. You want to check all your film, like all the planes, include your bony anatomy and critical structures. Always make sure we know what we're doing before we treat. We can't take back our radiation. So always take that extra step just to make sure everything looks good before we beam on. See, okay, so.
So the next patient is, patient has multiple sites in the mediastinum and chest, treating those all with a single VMAT IMRT plan. Here's the treatment planning CT. You can see these little volumes are the GTV. The PTV expands on those quite a bit. You can.
So for the sake of time, I'm just gonna kind of fast forward this a little bit. So he selected.
Scroll through it, Matt. Let's make sure that looks good. And then lastly, we'll take a look at what the soft tissues in those areas look like. Those areas where the contours are drawn for the target volume. So I'll turn my checkerboard off and I'll go through with Control A. And you're basically looking, as you focus your eye on the image, do the shapes match up? You can look for, this is a surgical clip here in this area. You can tell it's a surgical clip because of the artifact on it. So you can see that surgical clip is pretty close. I don't know if this is a surgical clip here or if that's a calcification. I think those are also clips. Those are always really good to have. If you have some sort of surgical clips or fiducials, those are your buddies. So scrolling through down here, you can see like the contours of the heart are all really, really close. And the tumors are adjacent to the heart and esophagus. This here, where my cursor is the esophageal contrast from the CT planning scan. You're not going to see the esophagus at all on the cone beam, but you know that this soft tissue here is the esophagus. So, you know, these other little, you know, shapes of the anatomy, okay, if the shapes are basically lining up, that's what you're looking for. You don't always want to get so hung up on, oh, what if I don't know what this is or that is? You know, that's okay. Last time I checked, radiation therapists didn't go to medical school, but we're definitely adept at looking at these contours and in making sure that things are looking the same. And when there's a chance that they're not looking the same, or if you just, you know, if you don't know what's going on, then that's when you want to call the attending radiation oncologist over to explain it to you so you know what to look for next time.
For this particular case, they have 3 different lesions. So it's definitely, you know, when we want to make sure we have the correct contours on, but I would also recommend having an alert or something that reminds us to tell the person who's driving that there is 3 different lesions that we're looking at, and we want to make sure that we're checking them all, because it would be easy to just not notice it, or just to like think that the 2 were on and then not know that there's a 3rd one. So I think it's always good to just have a note to let you know that there's more than one lesion that you're looking for. This is just another alignment video of a lung lesion that's right on the airway. So for this particular case, you want to use the airway for alignment. And then just always scroll through all your planes and make sure once you're aligned that you like the position. So we've gone over quite a bit of information. So we'll just go briefly over chest alignment. Once again, always check that you're on the correct vertebral body. Getting the first or last rib in your image is always a really good solid indication that you're on the correct vertebral body, especially if you're treating the spine or a rib. It's really easy for things to start looking the same. So I would say that's best practice if you move your imager up or down prior to doing your scan and taking the image, just to make sure you're on the correct rib. Also, the carina is a good landmark. You always want to shift to the area of interest. So like and then use whatever's nearby, the airways or a rib or whatever the doctor tells you to help for alignment. And then always scroll through your planes, confirm your PTV is aligned. And so this is just some take-home points. You always want to, especially if it's like a different case, ask the physician what they want to prioritize and matching. This goes to any site, you know, like if you're treating a head and neck, like how critical is the spinal position? What PTVs do you want to use? How critical is the bladder for a prostate? I think if you get a general idea of what the doctor wants on the first day, it helps you throughout the course. And then you could also make notes for anybody else coming in who is treating the patient. Always check other views and slices, scrolling through all 3 planes whenever you make an adjustment. Check the big picture, make sure that what you're treating is actually in the treatment volume, and check your critical structures. If you're ever unsure, always just check with the physician. I never regret it, even if it's like a dumb question and I ask, like, I never go home and think like, oh, why did I stop the treatment, like not do the treatment and take the second to call the physician. I would much rather ask for help and double check before beaming on. And then having a department policy is really good as far as like what we were talking about, Kevin said with the cone beams, like when do you stop cone beaming? When do you refilm if the shift is significant? When should I call the physician? Like what is acceptable and how are we planning? Because everybody plans a little differently. So that makes the difference. So that's about it. They have their further study. They have these different websites here that you can go to. And then this is acknowledgements. These are the people that helped create the slideshow for today. And then this is what's going to happen next time. Thank you all for coming. I hope this was helpful. Does anybody have any questions?
Please, if anyone would like to unmute and ask a question, please go right ahead. If not, we can always grab it from the chat. And until then, I think one thing I want to say, Whitney, is that was awesome. Thank you for those overviews. I think the videos especially were great. To be able to see those examples in action, I thought was a very nice touch. And I think your takeaway point of, having some sort of a policy, if I've learned anything now in this field, is that having everything documented of what you want to do. So that way everyone, therapist, physicist, doctor, they all know the expectations and what the tolerances are. It helps avoid confusion.
Yeah, definitely. Especially if you have different therapists, like a lot of therapists in a big department. It really helps to have a policy and everybody know what the expectation is.
Agree. Exactly that. Yeah, as you mentioned, like I cover a site within Elekta, but I also cover usually Halcyon and Clinac site. So even though they're different machines, and now different staff are involved, they all use the same policy.
Oh, that's good. Yeah. How do you like the Halcyon?
Fast.
Yeah.
Very few MLC breakages. But I've been working with a Clinac now for a number of years, and there are some things that are a little bit nicer. It holds your hand through a little bit more. Oh, there's a question in the chat. Like probably might be our last one. What is CBCT limit extremity if the shift is more than 25 cm? Oh, that might be machine dependent. Usually I think the TrueBeam automatically couch centers, if I'm not mistaken. I think the Clinac you have to manually center back to 0 if it sees that it will collide. I don't recall what Elekta does, if they do something similar with the couch centering.
Yeah.
I think that's a machine limitation though.
We sometimes we put patients on a slider bar, if they're on an index bar, and kind of move them over if we're at the limit. And then
so you catch them in the field of view. Oh, okay.
Yeah, but the older clinics, they make you 0 the couch, where the newer TrueBeams, you have the option. So it's really site specific. It kind of depends on the vert. So I don't know if the Elekta will let you. I know the old Clinac, it would make you 0 out if you slide over. And sometimes that's less helpful than just doing a partial scan.
Yeah. Oh, thank you. Great point. No, thank you so much. It looks like everyone is very appreciative of this talk. I thought that was if I had known nothing about CBCTs today, that would have gotten me up to speed very quickly. So thank you so much for taking the time to do this.
Thank you. Thank you all for being here. Thank you, Kevin, for all your help. You guys have a great day.
Thank you, everyone, for joining us. Have a great one.
Thank you. Thank you.